For over 30 years, oncology researchers called it the Death Star of cancer biology. It was the absolute holy grail of precision medicine, mutating inside some of the deadliest and most aggressive tumors on Earth. But every single time scientists tried to design a small molecule to stop it, they failed. The top laboratories in the world declared it completely undruggable. That target is the KRAS protein, a molecular switch that gets permanently jammed in the on position, ordering cancer cell to divide and multiply completely out of control. But the era of it being undruggable is officially over. Today we are breaking down the masterclass pharmacology behind how two breakthrough small molecules, Sotorasib and Adagrasib, did the absolute impossible. They cracked the code on the KRAS G12C mutation by laying a brilliant structural trap. If you want to master precision oncology, understand the subtle clinical nuances between these two therapies, and learn exactly how they silence hyperactivated pathways, let's dive into the cell. To understand how modern medicine broke this target, we must first look at the native genetic blueprint and physiology. The KRAS gene, short of keratine rat sarcoma viral oncogene homologue, is located on the short arm of a human chromosome 12, specifically at cytogenetic position 12p12.1. In a healthy human cell, this gene encodes a small GTPase protein that works exactly like a master homeostatic light switch for cell growth and survival. When the KRAS switch is bound to GDP, guanosine diphosphate, it's completely inactive or turned off. However, when a growth factor binds to an upstream cell surface receptor like EGFR, helper proteins called guanine nucleotide exchange factors or GEF are recruited. These GEFs kick out the GDP and swap it for a high-energy GTP molecule. Now the switch is turned on. In this transient active state, KRAS fires off a rapid, tightly controlled signal down a cascade known as the RAF-MEK-ERK pathway, also called the Mutation activated protein kinase or MAPK. Cascade. This tells the cell nucleus it's time for normal growth and division. Once the message is successfully delivered, KRAS uses its own intrinsic GTPase enzyme activity, aided by GTPase activating proteins or GAPs, to break down the GTP back into GDP. This turns the switch off and resets the cycle. It's elegant, it's controlled, and it keeps tissue in perfect balance. But what happens when the genetic hardware malfunctions? In non-small cell lung cancer and colorectal malignancies, one of the most common driver variations discovered via next-generation sequencing is the KRAS G12C somatic missense mutation. At the cDNA level, this corresponds to a single nucleotide point mutation. The guanine changes to thymine at position 34, specifically annotated as C.34GT. At the structural protein level, this single base swap replaces just one amino acid. The native glycine at position 12 is replaced by a cysteine. Now, if you want to understand more about single nucleotide polymorphisms, or SNPs in particular, and how mutations work in general, definitely check out the very first episode of our pharmacogenetic masterclass, which I've linked right up here and in the description below. Now let's continue. This single structural alteration has devastating biochemical consequences. The presence of that mutant cysteine residue profoundly impairs the protein's intrinsic ability to hydrolyze GTP back to GDP. Furthermore, it physically prevents GTPase activating proteins from binding to promote the conversion. The result: the mutant KRAS G12C protein is permanently trapped in its active GTP bound state. The molecular switch is glued on. It continuously floats the RAF-MEK-ERK pathway with unyielding growth factor receptor independent survival commands driving unchecked cell proliferation, tumor expansion, and oncogenesis. The cancer cell completely ignores the body's internal stop signs. So, how did modern pharmacology finally drug the undruggable? For decades, scientists tried to design molecules that could compete directly with GTP, but because KRAS binds GTP with massive picomolar affinity, kicking it out was biophysically impossible. International drug design and our first targeted weapon, Sotorasib, non-commercially as Lumakras or AMG 510. Sotorasib bypassed the GTP binding problem entirely by exploiting a hidden structure vulnerability. It completely ignores the hyperactive GTP-bound protein and instead waits patiently for the mutant KRAS to transiently relax into its active GTP-bound conformation. When it does, a tiny allosteric pocket opens up right next to that mutant cysteine 12 residue, known as the switch 2 pocket. Sotorasib dives straight into this pocket. Its acrylamide warhead forms a highly selective, irreversible, covalent bond directly with the nucleophilic sulfhydryl group of the mutant cysteine 12. By doing this, Sotorasib physically handcuffs the protein, trapping it in its inactive GTP conformation forever. GEFs can no longer execute nucleotide exchange. The downstream RAF-MEK-ERK pathway goes completely dark, and the starved cancer cell is driven straight into apoptosis or programmed cell death. Precision medicine, however, never stops evolving. Our second targeted weapon against this driver mutation is Adagrasib, commercially known as Krazati. While it shares the same foundational goal of covalently locking onto cysteine 12 in the inactive state, Adagrasib brings a unique chemical engineering to the clinical table. Adagrasib was built with a highly rigid wide ring core matrix. This specific spatial architecture allows the molecule to insert itself significantly deeper into the switch to allosteric pocket compared to earlier compounds. By penetrating deeper, Adagrasib maximizes its special interactions, establishing an incredibly powerful enhanced lipophilic interaction with a nearby hydrophobic subpocket. This tight molecular fit gives Adagrasib two distinct biochemical properties: a much slower dissociation rate and an extended target residency half-life compared to Sotorasib. It grips the mutant protein tighter and holds onto it longer, maintaining a continuous, unyielding blockade against newly synthesized oncogenic proteins before they can shift into their active states. Now, as advanced clinical practitioners, our rule goes beyond understanding how a molecule locks onto a pocket. We must master how the human body handles these drugs. While both agents are highly precise, their structural and pharmacokinetic differences lead to unique toxicity profiles and vital laboratory abnormalities that require rigorous clinical monitoring. Let's look at Sotorasib first. In clinical practice, the most common all-grade adverse reactions are gastrointestinal, specifically diarrhea, occurring in roughly 42% of patients, followed by nausea at 26%. Patients also frequently experience musculoskeletal pain, fatigue, and persistent dry cough. On laboratory panels, keep a close eye out for a drop in absolute lymphocyte counts, decreased hemoglobin, hypocalcemia, and hyponatremia. But the really clinical red flags for Sotorasib are two severe, potentially life-threatening class toxicities. Severe hepatotoxicity. Up to 38% of patients experience significant elevation in ALT and AST. Here's a critical clinical pharmacy pearl. Patients who received an immune checkpoint inhibitor within the preceding 3 months face a dramatically elevated risk of severe drug-induced liver injury, up to 40%. Liver function tests must be checked at baseline every 3 weeks for the first 3 months and monthly thereafter. Interstitial lung disease or pneumonitis. Occurring in about 1 to 2% of patients, it can be fatal. Any acute onset of unexplained pulmonary symptoms like dyspnea or dry cough requires immediate withholding of the drug. If ILD is confirmed, Sotorasib must be permanently discontinued. Now let's pivot to Adagrasib. Because Adagrasib achieves high tissue accumulation and has a prolonged half-life, its overall gastrointestinal toxicity profile can be more intense. Diarrhea and nausea affect up to 70% of patients, frequently accompanied by severe vomiting, profound fatigue, and a rise in serum creatinine. Furthermore, Adagrasib carries two unique safety parameters that completely differentiate it from Sotorasib. First, QT's interval prolongation. Adagrasib can alter cardiac electrical condition, significantly lengthening the QT's interval and risking life-threatening arrhythmias. Clinicians must assess baseline EKGs and strictly monitor serum potassium and magnesium before and during therapy, avoiding concomitant QT's prolonging drugs. And there's renal impairment. Approximately 36% of patients develop renal toxicity or acute kidney injury, making regular serum creatinine and basic metabolic panels mandatory. When executing bench to beside precision oncology, we can distill the core differences between these two direct inhibitors into 3 major clinical parameters. First, let's look at systematic elimination half-life. Sotorasib is cleared relatively quickly, possessing a half-life of approximately 5 to 5.5 hours. This requires a high daily dosing strategy of 960 mg to keep newly synthesized KRAS proteins saturated. Adagrasib, conversely, boasts an extended elimination half-life of roughly 23 hours. This 24-hour span allows the drug to steadily accumulate in tissues, providing continuous systemic exposure that oversaturates fresh mutant proteins as they are produced. Second, consider central nervous system penetration. Advanced non-small cell lung cancer carries a notoriously high propensity for brain metastasis. While Sotorasib exhibits very limited penetration across the blood-brain barrier, Adagrasib displays high brain-to-plasma concentration ratios, efficiently crossing the blood-brain barrier to deliver documented objective intracranial responses in active untreated CNS disease. Third, look at tumor histology. While both drugs work effectively as single-agent monotherapies in the subsequent line treatment of non-small cell lung cancer, treating KRAS G12C in colorectal cancer is a completely different biological ballgame. In GI malignancies, blocking KRAS triggers a rapid compensatory upstream feedback loop mediated by EGFR. To bypass this resistance, clinical guidelines dictate that KRAS inhibitors must be combined with an anti-EGFR monoclonal antibody in colorectal cancer, meaning Adagrasib is paired with cetuximab, and Sotorasib is combined with panitumumab. And as always, if you want to master the crucial foundational difference between pharmacokinetics, what the body does to the drug, and pharmacodynamics, what the drug does to the body, don't hesitate to click the link above and watch our related episode. To manage severe grade 3 or 4 toxicities in the clinic, we follow protocol-driven dose modifications. We never just stop therapy permanently if we can safely manage it through structured step-downs. For Sotorasib, we initiate at the standard dose of 960 mg orally once daily. If toxicity arises, the first reduction level drops to 480 mg once daily, and the second reduction goes to 240 mg once daily. If the patient cannot tolerate 240 mg, the drug must be permanently discontinued. For Adagrasib, the starting dose is 600 mg orally twice daily. The first step down drops to 400 mg twice daily, and the second step down goes to 600 mg once daily. Finally, let's talk about a major drug-drug interaction regarding gastric pH. Sotorasib relies heavily on the acidic gastric environment for adequate solubility and absorption. Co-administration with proton pump inhibitors like omeprazole or H2 receptor antagonists like famotidine significantly lowers sotorasib systemic exposure and should be strictly avoided. If an acid-reducing agent is completely unavoidable, the patient must utilize short-acting, locally acting antacids and stagger administration perfectly. Sotorasib must be taken either 4 hours before or 10 hours after the antacid dose. Now, as we deploy these targeted therapies into real-world clinical care, we run into the ultimate evolutionary barrier of cancer biology, acquired resistance. While Sotorasib and Adagrasib achieve remarkable initial clinical responses, the tumor genome inevitably adapts, typically within 6 to 12 months. As advanced precision clinicians, we must understand the precise molecular architecture of this resistance so we can anticipate failure and design the next line of combination strategies. Acquired resistance to off-state KRAS G12C inhibitors is highly complex and is broadly categorized into 3 distinct biological mechanisms. Let's look at the first category, on-target secondary mutations. On-target resistance occurs when the KRAS gene itself acquires a secondary missense mutation directly at the drug-protein interface. These secondary mutations physically alter the shape of the switch II pocket, preventing Sotorasib and Adagrasib from binding. So, a secondary mutation at tyrosine position 96, specifically Y96C or Y96D, completely eliminates the binding capacity of both Sotorasib and Adagrasib. It renders the tumor entirely cross-resistant to both agents. Interestingly, some mutations show drug-specific patterns due to structural variations. For instance, secondary mutations at position 95 such as H95D or H95Q or H95R severely disrupt the pocket fit for Adagrasib, yet the protein remains partially sensitive to Sotorasib. Conversely, mutations like G13D, A59S, or R68M cause extreme structural resistance to Sotorasib but leave the pocket open enough to remain sensitive to Adagrasib. Understanding these subtle variations in serial circulating tumor DNA, liquid biopsies can theoretically guide a sequential switch from one inhibitor to another. The second major category, and what occurs in over half of the resistance cases, is off-target genetic resistance or bypass signaling. Here, the KRAS gene itself doesn't change, but the tumor rewires its intracellular circuitry to bypass the blockade entirely. First, upstream rebound activation. When you shut down KRAS, the cell senses a drop in proliferation and triggers a massive compensatory feedback loop. It upregulates and amplifies upstream receptor tyrosine kinases or RTKs such as EGFR, HER2, MET, and FGFR. These active receptors fire up wild-type NRAS, HRAS, or downstream mediators to kickstart the MAPK pathway all over again. Concurrently, tumors frequently acquire mutations in PIK3CA or experience a loss of the tumor suppressor, PTEN. This drives a hyperactivation of the parallel PI3K, AKT, mTOR survival pathway. Recent translational data reveals that this specific bypass upregulates 4E-BP1 phosphorylation, driving cap-dependent protein translation that keeps the cancer cell alive despite total KRAS G12C inhibition. This is why dual inhibition with a PI3K or mTOR inhibitor is an active area of therapeutic research to overcome resistance. Finally, the third and most fascinating mechanism is non-genetic lineage plasticity. In multiple documented clinical trials, post-progression biopsies of patients who failed Adagrasib or Sotorasib showed that their lung cancer physically changed its lineage. The classic lung adenocarcinoma completely trans-differentiated into squamous cell carcinoma, or even high-grade neuroendocrine small cell lung cancer without acquiring any new driver mutations. Here is an essential genomic biomarker correlation. This cellular plasticity is highly enriched in patients who carry a baseline concurrent STK11 or LKB1 co-mutation alongside their KRAS G12C variant. Inactivation of the LKB1 tumor suppressor alters chromatin accessibility, allowing the tumor cells to smoothly shift their cellular identity to state that is completely independent of KRAS signaling. By mapping these on-target pockets, bypass loops, and lineage transformations, precision medicine teams can move past simple monotherapies and deploy rational, upfront combination strategies to defeat resistance before it even begins. From an untouchable, completely invincible oncogene to precisely targeted actionable mutation, the clinical story of KRAS G12C inhibitors is living proof of the absolute power of structural pharmacology and precision medicine. By trapping this molecular switch in its inactive GTP-bound form, we have rewritten the prognosis of thousands of patients navigating advanced non-small cell lung cancer and colorectal malignancies. If you found this comprehensive, deep dive, high yield, and valuable for your clinical practice, masterclass preparation, or oncology board exams, please hit that like button, subscribe to the channel, and drop your clinical questions or thoughts in the comments below. Stay sharp, keep learning, and I will see you in the next masterclass right here on NextGen Pharmacist.